From a clinical standpoint, it's been a great journey here, finishing out the phase 3 programs and the continued reporting of both the initial data sets as well as all the follow-up data sets, which we're getting out here as well. And of course, we have the outcome trial. 18,000 patients who've recently had a coronary event, an acute coronary syndrome, who are not at their LDL treatment goal despite maximal tolerated statins. It's going to be a great opportunity for us to demonstrate the sustained value of LDL reduction with Praluent for those patients, and we're looking forward to getting those results soon. It's going to be very important for our patients.
One thing that we've definitely heard is physicians see the efficacy as it relates to Praluent with the 75 and 150 milligram dose. They definitely see the flexibility as well. Utilization management criteria is still something that is of an issue, and we continue to look for ways to streamline those and make prescribing easier. But these are still barriers that are in front of physicians. So they see the efficacy. They're very curious to, of course, in the future when we have CVOT as well. But this is something that we continue to work on with them and help them. They help educate us, and we help educate them around these utilization management criteria. I think some of them are actually ezetimibe step edits. This is something that we are seeing, and patients actually being on the maximum tolerated dose of a statin and going through several months of this until they can actually maybe get through the barriers and be put on a drug such as Praluent. And again, that correlates to the data that will actually be, or some of the data that we will be showing later at AHA will help educate them and hopefully ease those barriers. It's certainly not easy, but it's something that I think physicians are getting more acclimated to. I'm also seeing a large movement of how key opinion leaders can actually start to be working with payers, et cetera, so that we can actually work collaboratively to make sure that the right patients are getting the medication versus a year ago where there was maybe not the same type of collaboration or not even knowing there was a need for that type of collaboration. But I think that's how, at the end of the day, it really matters for the patient, and I think we're all going to have to work together in order to make sure that they do get that medication. We don't believe cost is actually a factor. We work with PBMs, we work with insurance companies, et cetera. And I think it's more, again, of just going through this criteria to make sure that the patient has gone through all of these necessary steps of treatment, whether that be escalation of dose of statin and the addition of ezetimibe. And those are areas I think that we need to continue to look to streamline so that the patient can get a drug like Praluent sooner versus waiting.